Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Becky Dale with Minnesota Communities Caring for Children, and I am happy to welcome you and excited to partner with Dr. Wayne Jonas in this webinar today. I'm just going to give you a few sort of pointers for the webinar as we go. If you look, you should have a panel that gives you a GoToWebinar panel and lets you access some of the features of the panel. There is a handout. So on the panel, there is a handouts spot where you can look at and download a copy of the slides that Dr. Jonas will be sharing today, if you'd like those to refer to for future reference. Also, there is a section on questions, which is the place where you can type in questions that you may have. Dr. Jonas will be presenting for about 40 minutes or so, and we are going to then address questions at the end of the presentation. So I will take a moment when he's finished to invite questions, and you can type them in then. Also, though, if you think of them as you're going, you're free to type them in the box as you go, and I will keep an eye on them and be sure that we take a look at them when we get done with the talk. With that, I think I will just give a brief introduction of Dr. Jonas, and we'll get started. Wayne B. Jonas, MD, is a practicing family physician, an expert in integrative health and healthcare delivery, and a widely published scientific investigator. Dr. Jonas is the executive director of the Samueli Integrative Health Programs, an effort supported by Henry and Susan Samueli to increase awareness of and access to integrative health. Additionally, Dr. Jonas is a retired lieutenant colonel in the Medical Corps of the United States Army. From 2001 to 2016, he was president and chief executive officer of the Samueli Institute, a nonprofit medical research organization supporting the scientific investigation of healing processes in the areas of stress, pain, and resilience. Dr. Jonas was the director of the Office of Alternative Medicine at the National Institutes of Health, NIH, from 1995 to 1999, and prior to that, served as the director of the Medical Research Fellowship at the Walter Reed Army Institute of Research. He is a fellow of the American Academy of Family Physicians. Dr. Jonas has led and participated in hundreds of research studies, beginning with his time as director of the National Institute of Health Office of Alternative Medicine. While serving as CEO and president of the nonprofit research organization Samueli Institute, his work set the bar for evidence-based research in the area of pain, stress, and human performance. Dr. Jonas' new book, How Healing Works, was published in January of 2018 by 10 Speed Press. His research has appeared in peer-reviewed journals such as the Journal of American Medical Association, Nature Medicine, the Journal of Family Practice, the Annals of Internal Medicine, and the Lancet. Dr. Jonas received the 2015 Pioneer Award from the Integrative Healthcare Symposium, the 2007 America's Top Family Doctors Award, the 2003 Pioneer Award from the American Holistic Medical Association, the 2002 Physician Recognition Award of the American Medical Association, and the 2002 Meritorious Activity Prize from the International Society of Life Information Science in Chiba, Japan. So, as you all know, in our network of folks across the state of Minnesota, working to understand the impact of adversity in early childhood, the impact of trauma on the brain, and how we can build resilience, we are always hearing from all of you how much more you want to hear about how to build resilience. And hearing Dr. Jonas's experience, I'm sure you can see why we're excited to hear more from him about what he's learning and what he's sharing. We were fortunate to hear through a colleague of ours in Chicago when Dr. Jonas was in Minnesota not too long ago, and through that partnership, we're grateful that Dr. Jonas was willing to spend some time with us today over the airwaves in a way that all of you in many parts of Minnesota will be able to hear what he has to offer. So with that, I am going to turn off my camera and turn it over to Dr. Jonas, and welcome and thank you.
Thank you very much, Becky, and I appreciate the opportunity to speak to everybody out there dealing with children and dealing with trauma that happens to children, because that, as you all know, so often sets the pattern that leads to chronic illnesses. And as we're now discovering, those chronic illnesses are not just chronic illnesses that occur in the mind through depression, anxiety, and things like that, but chronic illnesses that also impact the body, probably every organ of the body, the heart, the lungs, and predispositions to other conditions. So childhood trauma gets carried forward into adult life, and often gets manifest and is linked back to chronic illnesses. But we rarely address that in healthcare. When we see adults and or children in those areas, the average physician is often so busy seeing them for their 20 minutes or to go through the checkbox of what's required for standard medical care, that really addressing these deeper issues of the whole person, the social and emotional body, and the traumas that have been carried forward as they move through their life, and that influence and impact those chronic diseases, are rarely addressed. And so I think what we need in the area of healthcare is that we need to, number one, acknowledge the research, and I'll be talking a little bit about that, both in terms of how trauma-informed care for children gets embedded in the brains and the body of children, and also how that gets carried forward, and the multiple ways we have to heal those if we will pay attention to that, and first of all ask questions about those and provide the kinds of what I call integrative health modalities to actually provide the kind of healing that's needed for those areas. So I'd like to spend the first 30 or so minutes just talking a little bit about what's going on in our healthcare system and why we need to shift to a more whole person integrative approach. And I'm going to illustrate that with a couple cases. These are a couple situations with adults, but as you'll see, their situations for full healing do require that they go back to and heal trauma components. Now let's see, I was told I can control these slides here. There we go. So you've heard a lot about healthcare reform, and you know, with the current administration, there was a lot of challenges to the type of prevention and more comprehensive care that was initiated through the Obamacare, and some of that now is in chaos in these areas. Most of the discussions, both in Obamacare and what's happening right now, are about payment, and about payment for the kind of health care that we currently have. And I believe that we're asking actually the wrong question, because it really almost doesn't matter who pays. The reality is we know that we all pay if we don't pay for a type of health care that is going to produce health and well-being. So the key question that we need to be asking is not simply who pays for what we currently do, but does what we currently do actually produce health and well-being? Because if it does not, then it doesn't really matter how much payment or who pays for it. It's not going to produce health and well-being. Let me illustrate this with a couple examples of patients. Both of these are adults, but as you'll see, the roots of their conditions go back to childhood. And this is, I want to illustrate what normally happens when individuals with chronic disease, in the case of Sally, a chronic pain and opioid use issue, major problem going on. In the case of Joe, cardiovascular disease, the #1 killer in the country. Sally was an executive VP. She was rushing to a meeting and she had a car accident. She ran into somebody. She went to the emergency room, got evaluated. They said it was musculoskeletal. She developed low back pain, was put on non-steroidals, told to go to physical therapy, and continued to go back to work. Then a few months later, she was lifting a suitcase to get on a plane, and she heard a pop, had excruciating pain down her back, went back to the emergency room, more tests, and now, since she'd been treated with non-steroidal, she was put on opioids. Needless to say, she liked the opioids, she continued to use them, and she continued to try to work. But she gradually developed a tolerance to that, and pretty soon, not only was she in chronic pain, but she was addicted to the opioids and began sort of the merry-go-round of visiting pain specialists, surgeons, sports medicine folks, family physicians, and others. Was sent to behavioral medicine where they wanted to do counseling. She refused. They wanted to do opioid recovery. She refused. And finally, she ended up in my office where we did a whole person integrative health visit. Her first comment to me coming in was, "I'm not crazy and I'm not addicted, I'm in pain, but I'm not getting the relief from the kind of care that I've been provided." Well, unfortunately, Sally is not unique. You have heard about the opioid crisis, I'm sure. 2 presidents in almost every state have announced it's an emergency, and I think Congress this week is going to pass a funding bill to address opioid problems, and it is a major problem. Major increase in opioid use over the last 10 years. Opioid deaths are going up, and it looks like we're on track to increase those deaths even greater in 2018. 12 million Americans actually are misusing opioids, usually and often for chronic pain and other areas. Now, this is not something that has escaped the need for as a pain management problem. In fact, the opioid is just the tip of the iceberg of what's really a chronic pain mismanagement problem. And many of the major organizations like American College of Physicians, the Veterans Administration, the FDA, DOD, the Joint Commission have all said we should be treating chronic pain with non-pharmacological approaches and not simply drugs and pills and procedures. Had they been listening to patients for the last 20 to 30 years, they would have known that people in chronic pain are using non-pharmacological approaches, except we used to just call them complementary and integrative approaches, things like therapeutic massage, yoga, acupuncture, spinal manipulation, and mind-body techniques. And so now what patients have been using are part of the current guidelines. The average physician or the average nurse practitioner, the average provider finds themselves caught between a rock and a hard place. The guidelines saying use more of these things, patients saying they wanted them, but not really being able to deliver them, both because they haven't been trained and because the team that deals with most people with chronic pain does not contain individuals with expertise on how to educate patients in these areas. Even more than that, the very approach that we have in the culture for doing chronic pain, including what patients are taught to seek out, is a pill and procedure process. Not only do providers not ask questions, but patients don't expect that the lifestyle approaches, complementary approaches should be discussed within mainstream encounter, and we do not have the ability within a 20-minute visit to properly identify or address some of those areas. And so the very first thing that needs to occur if we're going to shift over to follow these guidelines and do more patient-centered care is that we need to change the dialogue that goes on in the encounter, the day-to-day bread and butter when you sit down with a patient and you ask them questions. And those questions need to be expanded beyond the typical SOAP note, the subjective, objective assessment and plan that provides the pills and procedures, that looks for CPT codes for reimbursement, to a more whole person approach. And I call that a healing-oriented practices and environments approach, or HOPE for short. And I recommend that one of the first things providers can do to change this dialogue is to open the questions that go on in the encounter to not just what's the matter, but what matters to the patient. We do something called personal health inventory. We took it from the Veterans Administration. It's an easy 2-page questionnaire that you can give your patients that automatically communicates to them that we're going to be talking about more than simply their body, the external environment, that we're going to be talking about their behavior and lifestyle, their social and emotional areas, which for chronic pain and many chronic illnesses is key, and their spiritual and mental components. Why are they here in life? What's their purpose? We do that through a series of questions that get at their underlying determinants of health. And when we do that, we find out that the underlying components that eventually lead to healing. Now, for Sally, who had chronic pain and opioid issues, when we sat down and we did a personal health inventory and a hope note for her, seeking what mattered for her, this is what emerged. First of all, she was juggling medications. She was getting them from many different providers. She was taking some supplements on her own. She didn't know how they interacted, how they should be used together, and so she needed some assistance with that. When I asked her what she did for her own self-care for her pain, a picture of heat and stretching emerged. She got in a hot tub every morning and stretched for an hour, and when she did that, she could often go without medications till afternoon when she began to have to take something. When we asked about sleep and stress, it turned out that her sleep was dysfunctional and had been for many, many years. She woke up frequently, only got 4 to 5 hours of sleep, and that she didn't know that she was under stress. She felt like she was under stress when she was working, but now when she wasn't working, she felt like there was no stress. She didn't realize that pain in itself produced stress, upping the cortisol levels, the inflammatory processes in her body, which chronified her pain and contributed to the chronic pain that had not been addressed. She didn't have in her environment, in her home, a place to go where she felt like she could really heal. There was too much going on. She had 3 kids and her husband, and she just keeping all those balls in order didn't allow her to have time for herself. And most important, what emerged out of the discussion is that after she lost her job, she'd also lost her purpose, which was really important in life. I almost always, in a hope note, ask patients like Sally who have chronic pain and opioid issues what their childhood was like. And in the case of Sally, she said, not very good. As it turned out, she had had a lot of adverse childhood experiences, a lot of physical and emotional trauma, possibly some sexual abuse. And so I agreed. She was not ready to go into that and address those issues at the time, but it was clear if she was going to heal, those social and emotional issues may become important. So we put that in the parking lot for her, but now it was at least on the table, and we knew that at some point it would need to be addressed. Her immediate team, her integrative team, looked like this. Now, she'd had a conventional team before, but they weren't working very well together, and they were disjointed in terms of both specialists and primary care providers. But her team now looked like this: the physician, and it could have been a nurse practitioner or other provider working closely with the pharmacologist to help her with her medications. She needed a behaviorist, but she wasn't about to go in, nor was she ready to go into counseling. And so the behaviorist needed to operate more like a health coach that could assist her. A lot of her own self-care, the heat and the stretching, was very much like yoga, but instead of just going to a yoga class, she had tried that and hurt herself. She needed to have a professional yoga therapist who knew how to deliver evidence-based yoga for low back pain. And we found one of those to bring on to her team. We needed her family on board, so they gave her both a space and a time and a place to practice. And finally, we needed her mind and body on board to realize that her body was not the enemy, that in fact it was her friend, and she could learn how to become aware of it and control it. With this team, we were able to set up a regular behavioral change which allowed her to do daily yoga, therapeutic yoga for her back, And after about 2 months, her pain levels, which had been at 6 to 7, were now down to 3 to 4, and continuing those processes with some other behavioral components that were not psychotherapy. Remember, she didn't want that, but did address some of her adverse childhood experiences. Within about 4 to 5 months, her pain levels were now down to 1 to 2. She was functioning better, and she was looking at going back to work. This was after 10 years of hundreds of thousands of dollars of visits and interventions. This is what integrative health looks like. This is a different type of health care. It is the merger of both conventional medicine. We needed actually someone to help manage her medications, for example, and her behavioral components, with evidence-based complementary medicine like her yoga therapist, and self-care like the behaviorist health coach and her family that allowed her to embed those together. The intersection of conventional care, complementary care, and self-care is what I call integrative health, and this is the direction that we need to go to manage chronic illness. Now, I often hear an objection to this saying we don't have time to put those teams together and to bring the amount of time that's necessary in those areas. My answer to that is that we're already spending much more time than it takes and much more expenses by simply staying in the top circle here of conventional medicine and doing a pills and procedure approach. If we continue to have healthcare in the top of this approach and stay only in that top circle, we will get what we currently have, which is a healthcare system costing us too much. We also have the cultural aspects, and I've addressed some of that, but there are increasingly numbers of people in this country that can't change behavior because they actually don't have access to the resources. They don't have access to the basic behavioral components of self-care, such as food, nutrition, education, transportation, etc. These so-called social determinants of health. Without addressing these factors, we are first in spending. We're 37th according to the WHO in most health outcomes. By 2025, it's predicted that 25% of our gross national product will be spent on healthcare, which is unsustainable. And as healthcare gets more expensive, health disparities, the difference between the haves and the have-nots, is increasing. And so we're going in the opposite direction of equity. The National Academy of Medicine has laid this out over the last 30 years and shown that compared to other wealthy countries, we are getting worse in terms of our outcomes in 9 of the 12 areas they tracked. And so despite the costs going up, our outcomes are getting worse. Here's a graph that shows the U.S. health expenditures compared to a number of other more rich countries, charting the death, age at death, the life expectancy on the y-axis compared to health costs, and we have double the healthcare costs, but only the life expectancy of Czechoslovakia or Portugal that spend much less money in these areas. So clearly the value of current healthcare is being lost. And so if we simply expand that coverage for what we're currently doing, we're going to spend more, but we're not necessarily going to get better outcomes. The reason for that is that most of medical treatment, most of healthcare does not actually address the underlying determinants of health. Numerous studies have shown that if we were to get universal healthcare coverage of what we currently do, the kind of platinum healthcare that Sally had, we would only increase the population's health by 15 to 20%. And this is because most of health comes from things that happen outside of the doctor's and the provider's office. These include behavioral and lifestyle components and the social and economic or social determinants of health. Until we get out of the office and begin to address those, coverage in healthcare will not provide value to health. Here's an example of another individual. I call him Joe, 69, and he was suffering from the #1 killer in the country. His father had an MI at 65. He had smoked up until 35 and then stopped. He had hypertension at 42. He was in the Navy for 30 years, and when he left, he gained weight. He then developed diabetes at 55. He had good medical care with full benefits. He was the food guy. He had done food in the Navy. He had been a cook on a boat in which they had done everything from scratch when he first started, and he'd seen the evolution of industrialized food, which was on the outside was called fast food. Soon he saw other Navy people coming in. They wanted this kind of fast food, and so things began to shift over, and food from scratch disappeared, and food with high sugar, fat, salt content began to replace it. And in fact, the Navy personnel wanted that food because they grew up on it outside. So when he was asked to do more natural food, more food from scratch, he found he couldn't do it later in his career because they would just go elsewhere off base to get some of their food. He ate this way too, and over his career, Joan found that he had lots of soaps and he had a lot of diagnoses, and here's where it ended up when he finally came in to see me. Hypertension, he was on 2 drugs for that. He had an elevated cholesterol, 1 drug for that, a drug for his diabetes. He was told because of his obesity to visit the dietitian, but when he went and visited her, he said he knew more about food than she did and never went back. He was now post-myocardial infarction, where he got a stent that saved his life, and a beta blocker, another drug. He was told to go to cardiac rehab, which was largely exercise, which he didn't particularly like in those areas. So when he came in to see me, this was the list of his soaps, and we sat down and then did an integrative health visit and a hope note with him, asking him what mattered. What mattered to him first, again, was his medication management. He was on multiple meds and was confused about how to use them. His primary goal was to prevent further disease. He didn't want to die like his father at 75, which would have been less than 10 years from a heart attack. He was told that he needed to change his fitness and his food. The fitness part, which was paid for, he didn't like particularly. The food part he did, but there was no place he knew how to do that. And he knew he needed to change his family and friend interactions because his friends who he met at the club afterwards largely ate the way he did and had a couple drinks to boot on top of that. What he missed mostly was giving back to society, doing something while he was in the service that was for the country at large and for his group in a smaller venue. And since he had retired, he didn't have a way to do that. Well, as it turned out, there was a program, a new program that was outside of the clinic on the base that was about food. It was cooking for health. And it was only open to cardiac rehab patients, and he went to do it, and he loved it. He took to it like a fish in water, and he began to change his diet over an 8-week. They had embedded health coach in that area, and so we put together with that a new integrative health team to help him achieve his goals. Again, it addressed the provider and the pharmacologist, now the nutritionist, but the nutritionist who is an educator, a chef, who helped put the nutritional ideas into tasty foods, a health coach to help them embed it in their life. It involved his family and his friends when possible, and it helped him change his mind. Within the 12 weeks of that program, he lost 12 pounds, and his blood pressure began to come down, and he realized that this is something that he could pick up and do in his life. And so he began to actually join this program as the chef. When I saw him a few months later, he said, you know, this shouldn't just be for people that have already had a heart problem. I needed this 30 years ago. And I said to Joe, why don't you do that? And so he organized an additional class for anyone that wanted to prevent their risk factors for not just heart disease, but many chronic diseases like obesity, diabetes, etc. Now he'd regained his purpose, and a year later when I saw him, he was now off of all except one of his high blood pressure medications. He was no longer on a diabetes medication, and he had markedly reduced his risk factors for heart disease, as well as improved his overall well-being. What those cases of Sally and Joe illustrate is that when we engage in self-care, and that self-care can occur both in things that occur now and also things that formulate that ability to change your behavior. When we have a support for that, health and well-being improves. If we integrate complementary and lifestyle approaches in self-care, we have a different kind of health care that addresses chronic disease. The evidence shows that when patients are engaged in managing their own care, that they can improve in all areas. The question I'm often asked is, can we do this within our current system? And I already alluded to the issue that, well, how do we cover these kinds of visits and this kind of team? Sally, as we moved along in her care, did eventually want to address the underlying concerns that had been embedded in her brain from her adverse childhood experiences, and so we needed to address those in some way. But in fact, we can do this within our current system. Now, it is difficult to get reimbursement for these areas, but it is possible. Let me illustrate large systems that are starting to do this. The military is one. I work in a military setting, and it is a capitated system, and it is already implementing integrative health. This is with nutrition, it's with behavioral health that's now embedded in all primary care, including dealing with children and adults and families. Here's a picture of some primary care docs being trained in battlefield acupuncture, which is a simple ear technique that all pain providers, both in the DoD and in the VA, are being trained in, whether they're primary care or medics or even specialists in those areas, and will soon be rolling out. That in itself is offering a new dialogue. The VA has just started to roll out 18 centers of excellence in integrative health, and it allows patients to do a personalized health plan and set their own goals in these areas. It involves not only health coaches, but group visits, self-care, and complementary and integrative practices in those areas. So it is possible to do this within large systems. Often in systems that are fee-for-service, I'm asked, well, how do you cover this care? Well, there are innovative programs within fee-for-service systems and others that are beginning to address this. Most of those are focused on the top 5% of the patients that account for 50% of all medical costs, so-called patients with advanced illnesses. And those can be adults and they can be children. We address those, or the system is addressing those, by putting in care coordinators. They're sort of like system health coaches, if you will, that help individuals stay out of the hospital, out of the emergency room. However, that's only 5%. What we need is a system that addresses the other 95%. Those who are at risk with multiple chronic conditions, and those that are healthy that we don't want to develop multiple chronic conditions or get into that top 5%. And so an area of integrative health care can address that other 95% by working together with the care coordination that addresses the top 5%, that works with primary care specialists, hospital readmissions, lab and imaging prescriptions, and integrative health that deals with health promotion, lifestyle as both prevention and treatment, health coaches, groups, and integrative practices, and addressing lab imaging, drugs, and supplements in those areas. Right now, we have one foot in the boat of fee-for-service, volume-based practice, and one foot in the boat of this new approach, which is sometimes called value-based care, in which we need to go if we're going to address the healthcare crises that are facing our system. If we don't get in the boat in the full value-based care system, pretty soon the boat is going to leave the dock and we're going to fall right in the lake, as I illustrated before. So what can providers do in this area? You don't have to wait until full healthcare reform occurs. In fact, if you're holding your breath for that, you may turn blue before it comes. Integrative healthcare can be done right now. And on my website that I'll show you at the end of this talk, I'm populating this with tools that I'm drawing from around the country to show individuals that they can do integrative health now in their system. First, I suggest an integrative health visit, and there's some tools like the Hope Note and others that personal health inventory that reframe the questions and the goals. You can add simple methods like ear acupuncture, mind body, nutrition, and safe supplements, and advanced healing technologies such as heart rate variability biofeedback, CES devices, behavioral health apps, and telehealth. And then most importantly, redesign health teams so they address what matters to the patient and their underlying determinants of health, their personal determinants of health, not just what is the matter with them. And I've illustrated this. Patients can begin to do this themselves, and this frequently emerges out of a single visit that I have with a patient. I ask them all, what matters to you? Find your meaning. What brings you joy? And link that to your health behaviors. Ask providers to do an integrative health visit, and I give examples of how to do that for providers and patients. Go in and ask them to do that, and I show that on my website and also in my book. And develop your own healthcare team. Until we get a healthcare system that automatically provides these teams, patients have to put together their own complementary and alternative and conventional practitioners and assist in healthcare. So these are things that you can do in patients with patients right now, and patients can do on their own. I mentioned the Hope Note. If you go to my website, there I have a toolkit for how to do that, to change the dialogue. We're beginning to add in ways it can be properly coded so that you can actually cover the costs of doing these kinds of visits in the team, and I'll refer you to that to take a look at it. There's other tools we're adding on to the area, and a number of those. Recently we loaded one on addressing adverse experiences and adverse childhood experiences, and how that is key, especially in chronic pain and opioid use. And so I'd encourage you to go there. Let me say a couple things specifically about childhood and adult trauma. We now know that ACEs, or adverse childhood experiences, form a pattern within the brain that often sets the individual into a routine response that later on in life is not perhaps very functional. One of the best sources of information on that is by Bruce Perry, who runs the Childhood Trauma Academy in Houston, where he has documented the neurosequential, that is the sequence of behavioral and neurological patterns that occur in children, and has interventions that can help children undo those. But this is not isolated to children. Adults also go through adverse experiences. Perhaps we need another category called A's, or adverse adult experiences. As a person in the military, I see this a lot with individuals who come back and have experienced the traumas of war, suffering from PTSD. But individuals that undergo medical treatment, especially traumatic medical treatment, also suffer from PTSD. My wife recently underwent chemotherapy for breast cancer and surgery. She did imagery during that period of time, and now when she goes in to the oncologist, she has a reaction, a physical and neurological reaction that's negative. She'll feel the nausea just walking into the doctor's office, and this is a type of mini PTSD from the trauma. Both the child and the adult need to have that reset if they've experienced those areas. And there are many ways to do that. Many ways. For example, in the military, there's retreats which help soldiers reset themselves and re-engage with a meaningful life. For an example of that, I will refer you to a book by a friend of mine, Joe Bobrow, called Healing the Wounds of War, where he's shown within a single 3 to 4 day retreat the PTSD components, many of which are triggering childhood experiences, can be reset and coping tools be established. In the military, there's also desensitization, which is a way of retraining the brain. One can do that in both with positive imagery, and we've funded studies from our foundation looking at positive imagery for sexual trauma in childhood, which then gets triggered again in adults, and the imagery can allow them to re-experience and retrain their body. There's a lot of work now in psychedelics, and you've probably heard of the use of psychedelics when under the proper guidance can actually help people re-experience traumas in a more positive and healing way. One can do this without psychedelics, meditation, and journaling and imagery can also be used to do this. For that, I refer you to the work of Opening Up, James Pennebaker, a book on how to readdress childhood experiences. There's a wonderful center in Chicago called the Center for Trauma, Healing Equity, Health Equity, and the Neurobiology, or THEN, which deals with both childhood and adult adverse experiences and puts together the kind of integrative approaches I've just described in my talk for healing those areas. So to end, I'd like to say it is possible to do this. You don't have to necessarily be in a specific center that's doing it. You can do it every day. In fact, most of the needs for dealing with trauma, bringing in the social and emotional, come into primary care, and so addressing these in primary care is really where the bread and butter of scaling a whole person integrative approach is going to occur. I want to thank you for having me and for the opportunity to talk about the importance of integrative and whole person care in these areas, and I look forward to any questions people might have or comments and discussion. Thank you very much.
Thank you so much, Dr. Jonas. And thank you to everyone who's been listening. Now is the time to start typing in questions if you have any. I have my question panel up, and I'm ready to look for them and convey them to Dr. Jonas. And maybe, Dr. Jonas, unless there's something else you'd like to talk about while we're waiting for questions, I have a question I would toss your way.
Okay.
So we in Minnesota have been working a lot with local communities, and we partner with local collaboratives around the state, also with tribes. And in those cases, many of the people we're connected to and who may be listening today are probably not actually working in the healthcare system. And although some are, there are a few folks in our network who are, and also people. We're looking at encouraging ways for people to work across systems and from various points in a community, bringing a community together, shared learning to have similar understanding of how trauma functions. And I really appreciated the slide you had about how patients can be proactive in this too. And I'm wondering if you have had any experiences of how other members of the given community can influence the healthcare system to start using some of these approaches that you're encouraging.
That's a great question, and actually I think the community has the greatest power to change healthcare, because healthcare is probably not going to change itself very quickly, and we've seen that. And so the whole field, for example, of complementary and alternative medicine arose because of patient demand. Patients were already using this, and when they asked for more of these types of services, that's when the healthcare system began to change. And I think it's the same thing with this kind of integrative health and whole person health. If the community will go to the health system and say, I need your part in this, I need your part in this, in helping me to do this, because I've had the conditions or the illnesses that I'm trying to address dealt with within the healthcare community, and I'm addressing them outside of the healthcare community also. How do I get these things together? And that's exactly the issue. And if a a patient, if you're a patient or you're suffering this, and the next time you go into your doctor's office or into your nurse practitioner's office, who actually might be more receptive than many doctors, simply ask them to do an integrative health visit. Say, hey, I'd like you to do an integrative health visit. I'd like to sit down with you and explore the determinants of health that engage me and my community and the activities that I'm engaging in that, and integrate that with the kinds of approaches that you're providing me with in there. And when the provider says, well, what do you mean by that? Then you can pull out the personal health inventory, you can pull out the integrative visit guide, you can pull out the hope note component and say, this is what I mean by that. Would you set up and do a visit with me on that? And if that happened, then there would be increased pressure to have that happen, and the healthcare community and healthcare folks could learn about that. Also, there are a growing number of councils for health hospitals that are patient councils that have to do with community and patient-centered councils, and those councils are the opportunity to bring to the healthcare system this opportunity to begin to work together in those areas. And so I think if the councils then go to the board of the directors, many of the people on the board of directors of healthcare systems are patients that are using more holistic and integrative practices, and say, we want you to do this better. And the healthcare systems will respond to that better than any kind of healthcare policy. And often they have the resources to begin to do that. And those councils can begin to do that. Several years ago, we did something called Wellbeing in the Nation, and you can look up wellbeinginthenation.com or .org, and it actually describes exactly how to put together the joint efforts of more whole person, well-being focused types of community-based training organizations and councils that actually bring together the community and the healthcare system to work together. So those would be a couple of my suggestions.
Wonderful, thank you. And our audience seems to be shy. If anybody's got any brewing questions, please do take a moment to type them in on your panel, on the GoToWebinar panel. Also, I'll mention again that there is a section on handouts where the slides are available, so now would be a good time to download those before the webinar is over, if you want to be able to have them to refer to later. We will also be sending a brief evaluation we'd love for you to fill out after the webinar as well. You'll get that in.
I'll mention one other example in which that can facilitate or stimulate or move communities and patients and health providers to begin to work better together on patient-centered teams. One, and that is putting together a true integrative health record, electronic health record. So you know most health records are built for reimbursement. They're not built, they're built for the SOAP note. They're built to find out what CPT code can I incur so that I get covered. It is only partially viewed by the provider. It can be viewed by some patients. It may or may not be able to be viewed by other members of the health team. For example, the yoga practitioner, in the case of Sally, couldn't actually log on to the health record and be part of that. And so it's possible to build, and there are places around that are doing this. Again, some examples are on my website, but we're doing this. We're building a true health record, electronic health record, using apps that sit outside of the medical record but can be accessed by the provider, by the patient, by the health coach, and by the community. The permissions are built into that, so it doesn't violate any kind of HIPAA laws, for example, and it allows, for example, the personalized health inventory, out of which a more integrated health plan can emerge to be viewed and managed by all of those groups: the patient, their family, the community, the health provider, and any other people on the healthcare team. This allows people to keep the patient-centered goals front and center. in terms of what the team is working for, and there are in fact now ways that you can track the success and accomplishments around the goals that are set up in the personalized healthcare plan so that they can become successful in terms of changing the kinds of personalized health behaviors that are needed to inherently tap in to one's own healing capacity. And so the electronic health record, but a health record accessible by all through an app, is fairly easy to do, and communities can actually build those kinds of things for their local environment.
Wow. It sounds like there's a real wealth of resources on your website, too, that people can refer to when looking at how to start thinking about some of these things and potentially working for them in their own communities. So that's awesome.
Well, we're working on that, and I'm in the fortunate position to be supported by a nonprofit foundation, the Samueli Foundation, which is simply trying to provide these kinds of tools and make them available for widespread use. So everything on our website is completely free, nothing commercial on it, and it can be used. Feel free to take it and use it. And we're actually looking for any other tools that look like they're useful to provide more whole person integrative care that providers and practitioners and communities and patients have found useful out there. And so please send us that information, contact us, communicate with us, and we'll have our team work with you to try to make those things more widespread and available also.
Wonderful. And you should all be able to still see the web address on the screen, drwaynejonas.com. There was a mention in the comments that there's a healthcare organization that is connected to the network throughout the state that we work with that probably would be quite interested. And so we're definitely able to make some connections. So that's exciting. I do have another question. You mentioned on your website also an ACEs tool. And because the newer understanding of the impact of adversity in childhood on the whole lifespan, on not only our physical health, but also our mental health and our social well-being and our community well-being, we're particularly interested in that. I'm curious if you could say a little bit more about the ACEs tool that you've developed.
Yeah, actually, I'd love to have an ACEs tool on our website and make it available.
I thought you mentioned that, but I missed that. Oh, okay.
I did mention that embedded within the integrative health questions of the Hope Note are questions specifically about social and emotional dimensions of a human being. And embedded in that, we do ask the question about childhood experiences. It isn't a formal ACEs tool, but it is in the assessment of the whole person, making sure that that question does not get lost. If a person has a chronic illness, then frequently in the 20-minute vignette, that kind of thing gets lost. And so it's a way of opening that conversation within a standard whole person integrative visit. And so there is some questions on that within the Hope visit. But it isn't a specific ACEs tool. What would be great, what I'd love to do, if any of your listeners out there have a simple, quick, easy, and validated ACEs tool that then could follow up on that we could use on that, we would be happy to actually take a look at that and make that available through our website and link it up with those areas. I know that if a patient comes in and if the environment is right, you can begin to ask questions about adverse experiences, but sometimes it's a big challenge. It's a challenge to do those. And so we simply open it up in a non-stigmatizing way by asking how were the experiences in childhood. And if those things look like they're a place where the patient needs to or is ready to go, then a formal ACEs kinds of questionnaire would be wonderful to have. To be on part of that. We have something called the Personalized Health Inventory, and I mentioned the VA is using this, and we've merged that with an integrative health visit, and I would recommend everybody to look at it. And you would be amazed that even without a formal ACEs tool, how often somebody will write down on that kind of open question thing, well, I'm dealing with some issues and trauma issues that have been hard for me to address, and that can be an open discussion for saying, would you like to address those and moving forward with them on that. And so if people have an ACEs tool, please contact with us. We will I'll put that down as a note to try to make sure we make it available and link it in. But take a look at the social and emotional questions in the Hope Note. We also have a version of the Hope Note that is Hope Note with social determinants, in which we've gone through and drawn from the upstream questions, the so-called upstream questions, which is a set of validated questionnaires about social determinants, asking about food, transportation, about safety issues, both in the past and currently, that may be the most important thing that matters to the patient in those areas. And so that's a way of getting some of those same factors.
Sure, yeah. It's really exciting to see your thinking and the hope that's embedded in healthcare systems starting to look at how do we really integrate, as you say, all of those pieces of the social determinants of health, and also when you talk about it in Sarah's story too, or is it Sarah or Sally? I'm not remembering, but
right.
That you made space for the early adversity to be addressed, and simply opening that up for possibility makes a big difference. And I think there are many, many different places that are looking at a variety of different ACEs tools around the country in healthcare and so on. And what we've learned from many folks that we've worked with in this field is that often the simple awareness of what happened to you early in childhood may be impacting an acknowledgement of those hurts, of those early hurts, can help start the healing process of them and actually impact the healing of other subsequent issues as well. So your approach to make space for those in the questionnaire and follow the patient, the patient's lead in many ways, is exciting to hear about as well.
Yeah, something you mentioned the communities and the importance of the communities to do this. And again, I work in a healthcare setting, so a lot of my experience and the approaches that I take is embedded within a healthcare setting. But the personalized health inventory, which is a quick way of getting at what matters to the person, that doesn't have to be used within a healthcare setting. That can be given to anybody, anywhere, anytime, and in fact, the way the VA is using it is that they're giving it out in some of the community centers where veterans come to get some of their care around group visits, around drug and alcohol issues, even some of the well-being components, the recreational components that are being provided to them in those areas. And so the personalized health inventory is a very easy, it's a quick 2-page thing that asks what matters, where are you on your health journey right now, and then it gets a quick scoring system that the person goes through asking about these underlying behavioral and social issues that we know are the primary drivers in health care. And you could give that out in a YMCA, which I know you're working a lot in Minnesota with on that. And then if things emerge that require medical care in that, then that then becomes a framework that can lead to a more integrative health visit when they go in to see their doctor, and they can bring that with them, or if they have it embedded in an electronic app or something like that, their health provider can access that way too. And so it's something that is widespread use, and the VA has tested this and found that it's very useful. And as you know, many veterans have had significant childhood experiences in addition to ones during adulthood, and so it's a way to open that dialogue in any situation, in any environment where you work.
So it really allows people to take leadership in their own health, and it's a tool that is a tool that's on your website that people can access. Is that true?
Yes, personalized health inventory is on our website.
So communities can share it with their members, and individuals can use it to start taking leadership in their own health and even in their conversations with their care providers.
That's exactly right. We drew it from the VA, which has free information on this and its use, and have adapted it to use in other settings. And you're free to adapt it. It's totally in the public domain. You can take it, pull parts of it out, put your title and logos on it, however you'd like to do it.
Wow, wonderful. It's rare that there are gifts like that, and how helpful they are in terms of keeping the work moving forward. If people can freely use great ideas, that helps. So thank you.
Our goal at the foundation is to spread this as rapidly and as widely as possible. And I know that your community is some of the people doing that already in their day-to-day work. So really love the alignment.
Great. Thank you so much. Well, with that, I don't see any additional questions. And so if somebody has one, they'll have to type quick, because I think we're ready to move to wrapping up this morning. So really, thank you so much, Dr. Jonas. We really appreciate your taking your time to share your experience and your stories and your resources with our network of folks looking at building healing across Minnesota. We thank you for your time.
Well, thank you very much, and it's wonderful what you're doing up there in Minnesota, and I look forward to seeing the continued work that you're doing and the accomplishments spreading to other states. So I hope I can come up and visit sometime and look at the examples that are up there and spread the information about that as much as possible.
Great. We'd love to have you. You'd be welcome. Thank you so much.
Take care.
All right. Take care, and thank you, everyone. Have a great rest of your day.
Okay. Bye-bye.
Bye-bye.